Well, it's almost midnight, August the 12th, waiting for the surgery crew to get ready. We have to put a stent in a elderly lady with an infected stone. So I thought we would talk about some things that people have brought up as questions, and a common question really is, where does bladder removal fit for this condition? And the simple answer is almost never. But there are situations where patients are not able to take an antibiotic, either orally or IV, long enough to take care of the problem, and they essentially give up. Again, it should be exceedingly rare to have to resort to that. Unfortunately, I've had a patient commit suicide with this particular disease, and that was clearly a case where, bladder removal would have benefited. I don't think it's likely that it should be done very often, but obviously in a case where the pain was not able to be controlled, it could have been used. So cystectomy for chronic bacterial cystitis would be different than cystectomy like for bladder cancer. Typically in female cystectomy for bladder cancer, the anterior surface of the vagina, the anterior wall of the vagina, comes out with the bladder as an extra layer in case there is penetration outside of the bladder into the vagina, that there's nothing left. So when you do that in the cancer patient, take out the anterior surface of the vagina with the bladder, and then you sew the vagina back together, and that can result in some narrowing and sometimes some shortening of the vagina. But the vast majority of patients that have interest can resume a penetrative sex, this is different than patients with chronic bacterial cystitis. You're not trying to prevent a malignant escape, so you can preserve the anterior surface of the vagina, and there's no narrowing, there's no shortening of the vagina. On the other question that a lot of people ask is, where does NeoBladder fit for this condition? And most of the patients have significant urethral symptoms. So to think that somebody that has diseased urethra, that you would actually preserve that and create a NeoBladder and bring it back down to the urethra in patients with infection seems like a really bad idea, and that's not something that I would consider doing. Most patients with this condition have had enough of their urethra and want it gone. So I don't think that NeoBladder really plays a role. It can certainly be done. It can be done very easily. But I think that you're looking at getting the lower urinary tract removed. Again, it should be very, very rare. So when you don't do a a NeoBladder, basically creating a new bladder out of either small or large intestine and bringing it back down to the urethra. That leaves you with your bladder's gone, the urethra's gone, so you have the ureters dangling from each kidney. So what do you do with your urine production? Well, there's two ways that it can be handled. You can have a urostomy created. A urostomy is essentially a 20 centimeter section of ileum, small intestine, that with each ureter hooked into one end and the other end hooked to the skin, and the urine is excreted via the kidneys into the conduit, the intestinal conduit, and then it collects in a bag that is hooked onto the skin that's basically with glue. It's no different than a colostomy or an ileostomy, where stool is collected in a bag. In this situation, the urine is collecting in a bag. That's a relatively simple procedure with relatively few complications. There are other ways to manage the urine if you remove the bladder, and that involves more complicated procedures where there are pouches created internally. The kind that most people use and the kind that I create is called an Indiana pouch. In an Indiana pouch, you use the right colon and a small section of ileum, and then you hook the colon and the ileum back together. And you take that section of colon and you cut it, fold it a couple of times, and it basically just turns it into a bag, a reservoir. So that's called a continent urinary reservoir. So basically this reservoir is internal. A small incision is made in the skin where the tapered ileum is brought out to the skin, and this ileal segment is continent. There's some fabrication where the ileum enters into the colon, and it prevents the leakage of urine backwards out the skin. And the patient catheterizes this intestinal reservoir, usually every 4 to 6 hours. We try to have a minimum of about 500 cc's capacity, and many times after a long period of time, they will be quite voluminous and hold 600 to 800 cc's, making catheterization relatively infrequent. It's more complicated. It's more risk for complications, common complications from the Indiana pouch. There can be problems with the way the pouch is connected to the skin, where you can develop stenosis, stomal stenosis, and probably the most common major problem is developing anastomotic stricture, and it's usually on the left side, where the ureter is anastomosed into the colon. You can get narrowing, and you can have to dilate those, or you can even have to go in and repair that. But that's a slick way to not have an appliance on. Nobody can really tell that you have it. You have a little Band-Aid that they keep over the stoma. You can't see it. It works pretty good. Obviously nothing's as good as having a bladder that functions. And again, it's very rare to have to do any of these things for this condition. Most of the time, if you're patient, if you can find the right antibiotic and stay on the right antibiotic for a long enough period of time, your bladder can heal. So it looks like they're ready to go to surgery. I will check back with you later. Have a good weekend.